Welcome to MTA International USA Studios in Silver Spring, Maryland, and to Open Forum. Today we're going to talk about pain. No pain, no gain. We've all heard that statement. Today we have three specialists here who specialize in pain management. How do we deal with pain? How do we manage pain? Is it curable? Is it something we have to live with? We have three great medical professionals who are going to talk about this. From my far end of the table, we have Dr. Abdul Qaddus Shahid, an international pain specialist, an anesthesiologist, a palliative care specialist, and he's done research in spinal modulation. He's married with 3 kids and loves to swim. Welcome to the show.
Thank you.
Next we have Dr. Amir Shakur Malik, who's a neurosurgeon in Houston, Texas, treats diseases of spine and brain, and surgical and non-surgical management of pain. He's married with 2 kids, loves to golf and swim, and he's done research in brain injury and spinal cord injury. Welcome to the show.
Thank you.
And third, we have Dr. Vaughn Aladin, who works in chronic and interventional pain management, physical medicine, rehabilitation, addiction medicine, and manual medicine, acupuncture, homeopathy, medical marijuana, and many, many other areas. He's done research in various areas, including thoracic spine pain and pain of the disc. Welcome to the show.
Thank you.
And by the way, you have 5 children, happily married with 5 children.
Thank you very much.
So, Dr. Shahid, size this up for us. What is pain management? Is this something that's make-believe and then we shouldn't have any trust in, or is it a real discipline in medicine?
Absolutely, it's a very real problem and a discipline that has evolved over past 3 decades into a formal specialization. For instance, I'm an anesthesiologist, and I've actually gone through further education and specialization to understand and treat the chronic pain. Pain is the primary cause for majority of our patients to see physicians across the board. But when that pain becomes chronic, that is when specialists like us...
What does chronic mean?
So chronic pain is any injury is expected to heal on its own. When the injury does not heal, that disorder is considered chronic pain. Usually we say 3 to 6 months window. That is the amount of time we allow for the natural rehab or the healing process to take place. And if that does not cure or rehab itself, then the pain is considered chronic.
Great. Now, Dr. Aladin, can't you just surgically remove the pain, if you will?
I wish it was that easy, but pain is actually called the 5th vital. It's something you can't measure.
What are the other 4 vitals?
Well, you have the blood pressure is one of the vitals. Pulse is a vital as well. Temperature and your respiration rate, the rate at which you breathe. Those are 4 vitals that are measurable. But pain, if somebody says, I have 10 out of 10 pain, they may in fact have such a degree of pain, or they may just want some certain medication from you.
So it's difficult. So there's Dr. Malik, there's surgical and non-surgical ways to address pain management?
Correct. So, say for instance, if you were to take back pain, there are many common ailments that give you back pain. Bending and picking something up heavy, you can get back pain. You can sprain a muscle. Usually will heal in a few weeks. Now, if you herniate a disc and you have pain that goes down the leg, it may or may not go away in a couple of weeks.
If I've herniated a disc?
So the difference would be that a pain that lasts over 24 hours, or that is not only localized to your back, but also is now going down either into your hip or down in your leg. So you know that there is something more than just your back muscles which have been strained.
So how do I know if I'm sore from working out, or is this real pain? I mean, how do I as a patient discern between the two? After 24 hours, I've been sore before as well.
But then again, he's mentioning if the pain goes down the leg, or if it's a disc in the neck, for example, it goes down the arm. If there's numbness or tingling associated with the pain, these are more often signs of a disc, especially if the pain worsens when you bend forward or when you lift objects. Whereas if the pain is worse when you bend backwards and maybe worse in the morning, these may be more related to the joints of the back or be a simple strain as Dr. Malik has just described.
Great. So back pain, I do not want to have surgery. What are my options?
So your options are, we always in medicine want to start with most conservative options. Just simple physical therapy, medications over the counter are going to be the first step in the management
Are
of
you talking
pain.
about Tylenol?
Tylenol, ibuprofen over the counter. If these do not alleviate your symptoms, definitely this is the time to speak to your physician. Formal physical therapy, re-strengthening the opposing muscles, is a natural way of introducing an accelerated process of healing. And if that doesn't work, then your physician will then refer you to a more specific treatment option.
So this is where you come in, Dr. Malik?
Well, let me just state that we've all heard an ounce of prevention is better than a pound of cure. So in the best case scenario, you're better off not having pain. And if you can learn to do a few things which prevent you from having back pain or neck pain, which we call healthy back or healthy neck habits, then hopefully you won't have pain.
What are those few things?
So, prevention is simple. Everybody knows what their limits are. All of us have strained our backs. We know what we did when we strained our back. We were either trying to move, lift, shift, twist, turn, push, pull, one of these movements which caused back pain.
So are you talking about like bend my knees when I pick up something as opposed to bend over to pick it up?
Exactly.
Okay.
So simple things. Try to keep your back in a neutral position. As best, when you're bending to pick something up, try to keep your back in a reasonably neutral position. Don't lift things which are beyond your ability to lift.
Right. Okay. Okay. Anything else?
As he said,
Prevention.
Is important. An ounce of prevention is definitely better than a pound of cure. If you go to the gym, do your Roman chair exercises. Do a lot of core stabilization. Strengthen the abdominal muscles. I have few patients who have very strong abdominal muscles. Number two, what's your diet? Every pound on the belly is interpreted as 3 pounds on the lumbar spine.
Wow.
So if you say leaner than I do, which I would recommend, you're better off.
Great.
And stay active, stay agile, and of course the proper techniques as mentioned for lifting. If you do get an injury, physical therapy is key. Now, if that disc falls out of place, as we mentioned before, and that is causing a sciatica or a pain that goes down the leg or the arm, Mackenzie exercises, which force you to extend, press-ups and Supermans, these exercises cause the disc to go back into place. That's the first thing to try, along with anti-inflammatory medications like your ibuprofen and your naproxen, as well as maybe a muscle relaxant.
Okay, so we've established prevention would be great. What if my pain is beyond prevention? It's there. What do I do next?
Well, obviously the first thing is go to your doctor, make sure that it's properly diagnosed. And I typically recommend, if a pain does not last beyond 3 to 6 weeks, and that's a big window. Usually all you have to do is oral pain medications, a little bit of rest, and prevention. Simple things that we talked about. If it lasts over 6 weeks, most likely you would need some form of an imaging study like an MRI.
So beyond the ibuprofen, these stronger medicines I've heard of, oxycodone, I mean these very strong medicines, I heard they're very addictive, and I've also heard that the pain doctors here really prescribe these, but they're not a cure. Most people get addicted to them. Why do you do that?
What you're saying is absolutely correct. There are different philosophies, and the pendulum has swung both ways over the past 3 decades. Initially, we were thinking these medicines were no good. Then came about a new philosophy that treat pain as the fifth vital sign and give as much as needed, and that led to an epidemic of exactly the problems that you're stating. Now we have gone through this experience, and we understand that responsible prescribing is very important, and that's an onus placed on pain physicians. And this new thought process is...
Well, when does it make sense? When does it make sense to prescribe? So I assume you guys are responsible physicians. When does it make sense to give a patient that strong medicine that could be addictive and could cause them other
side effects.
Side effects.
As we are progressing in this conversation, we have said first treat it with least invasive options, over-the-counter medications, exercising.
We're beyond that now.
We're beyond that. We have now had an imaging study we have now established that there is either nothing wrong on imaging and pain persists, or there is some pathology underlying. Either case, there is pain, needs to be treated, other options have failed. Now is a step where we can think of maybe adding a medication.
Such as
Vicodin
Okay.
or oxycodone. However, in an open
Those are the two most common?
correct. However, an open discussion and an appropriate consent from the patient is necessary with complete disclaimer that these medications are addicting and these are the possible potential side effects
Okay.
to their health.
Do you agree with Dr. Shad?
He's correct in that we should avoid these medications when possible. But a patient comes in with extreme pain such that they're unable to go to work. Pain is shooting already down their leg, and they're barely able to walk. Agreed, you have to give the anti-inflammatory. Give your ibuprofen, your Advil, and so on, or your naproxen, and so on, Aleve, and then also a muscle relaxant, and then maybe a mild opioid like tramadol. That type of a very mild, very low addictive qualities to it first. Put them on physical therapy. Why not add acupuncture? Acupuncture is also very beneficial, as well as manual medicine, chiropractic care. These complement these medications.
But aren't all these medicines, I understand about acupuncture, we'll get to that in a second, but aren't all these medicines so addictive that the risk in a patient's life is too much?
There is a risk of addiction, it is true. But then again, if this medication, as a Percocet or Vicodin, oxycodone or hydrocodone, as we mentioned, keeps that patient in work, look at the value of that. The number one cause of disability in America is the upper respiratory infection. Number two is low back pain, which we were talking about today. Number two is low back pain. So if all these people say, you know what, they're not going to get the medication, if the physicians say that, and they're out of work, how many billions of dollars will be lost to our economy?
So now tell me, when do you transition a patient from medicine to perhaps what Dr. Malik does or towards the surgery option?
Generally, the guidelines are 12 sessions of conservative care. That includes physical therapy, as we mentioned before. After you've reached 4 weeks of about 3 sessions a week, pain is not improving. That's the time when interventional pain gets involved. Maybe it would be a transforaminal nerve block or an epidural type of injection to help this person's pain. That's when this imaging has to be done, an X-ray and an MRI, and maybe a nerve conduction study to test the nerves and electromyography.
When do these patients end up in front of you?
So usually when all these modalities have been used, so they've done physical therapy, they've done oral pain medications, they've had injections, nothing is working. And they have an MRI which shows they either have a disc herniation or they have stenosis, meaning some narrowing of the spinal canal and the nerves are being pinched. That is when usually surgery comes into play.
And what happens at that point?
So the most common surgery that we do as neurosurgeons is called a laminectomy. Laminectomy. And what that entails is removing or trimming portion of the bone of the spine just to take pressure off of the nerves. That's the most common one.
Why is that considered so dangerous?
Laminectomy actually these days is a reasonably safe procedure. We can take, I usually quote the example that if 30 years ago, out of 100 patients, you would have 10 to 15 patients that would have a complication. Today, out of 1,000 patients, you'll probably have less than 5. Wow. So the complication rate over the years has gone way down, and it's primarily because of improvements in anesthesia and our ability to visualize, which is using the microscope to do surgery.
But I've heard this common perception that make surgery your last option. Try to treat it any other way, but don't go underneath the knife, if you will.
Yeah.
Why is that?
That is a wise thing to do. I would say go through every possible option that you can think of and exhaust every non-surgical modality of treatment before you come to us. Sometimes, like I said, it's probably better to seek surgical opinion sooner in certain diseases. And because all of us treat similar diseases that overlap one another, we have now realized that certain abnormalities in a person's exam, like if they're starting to drop things from their hands, meaning they're getting weak in their arm, or if they're starting to stumble while they walk, meaning there's some gait abnormality, they're having problems with their bowel and bladder, they're losing control of their bowel and bladder. It means the compression of the spinal canal or the spinal cord or the nerves has gotten to a point where these activities of daily living are starting to be affected. So in that situation, actually managing it with an injection or physical therapy becomes counterproductive.
But I'm a little confused now. At first I thought, doing all this thing is great, but if the risk is 5 in 1,000 with complications, why wouldn't I just come straight to you, take care of it, get it out of the way, and be done?
There are a few patients that come straight to surgeons. And then the onus falls on us to get an imaging study, properly diagnose what the problem is. Invariably, I would say 7 or 8 out of 10 patients that I see, I'll end up either sending them to physical therapy or sending them to a pain management doctor because they invariably will not need surgery.
So the best path to you is through after they've been to Dr. Aladin or Dr. Scheid.
That is one of the paths that they take. Correct.
So why is that a better path? Why not? Why shouldn't I just go straight to Dr. Malik?
Let me take a step back.
Okay.
You have chest pain. You go to your primary care doctor, or you have chest pain. You think of going to emergency room. In the emergency department or the primary care physician is not going to think of sending you to a heart surgeon immediately. Why?
Okay.
Because there is a less invasive way, and that is the way of thinking of a reasonable physician. Apply less invasive option first. They're going to send them to a cardiologist or interventional cardiologist, depending on what the need is.
So you guys
so we are equivalent of the interventional cardiologist, whereas the neurosurgery is more like a thoracic surgery.
So beyond medicine, you were mentioning you do some shots and things like that. What do you do?
I do shots, and as was mentioned before, these shots, or that we call epidural type injections, they can prevent the patient's pain from getting to that extent that we would need an open laminectomy or a fusion. Now, you're asking why come and do an interventional procedure first when the risks are low. That is with a laminectomy, but there are so many failed laminectomies that it has its own CPT code, 722.83, 0.82, and 0.81. Post-laminectomy syndrome in the lumbar spine, the low back, in the thoracic spine, and in the cervical spine. And if you go to the level of a fusion, 1 out of every 3 fusions at the 5-year.
What is a fusion?
When you join 2 vertebrae together. So after you remove the lamina, if you join the vertebrae together to remove that disc, which is compressing the nerve, then that is called a fusion. And the rate of success of fusions by many studies, especially in the U.S. here, show that 1 out of 3 fusions at 5 years is a success. The other 2, the patient would say, either I'm worse or I had no need for the surgery, I was better off not having it.
So there's certain surgeries that don't make sense. Now this is getting interesting, and I'm learning from this process.
So, back pain, neck pain, and headaches is a reasonably complex pain syndrome. Unfortunately, we have, or fortunately, about a 35 plus year history of treating these problems in this country. Because medical care is so prevalent, we have now gathered a large amount of information that is probably not available anywhere else in the world. So in Pakistan, if somebody comes to you for back pain, invariably they'll get a single operation. If a single operation doesn't work, they either can't afford a second operation or probably will not get a second operation. Here, one doesn't work, you'll get a second one. If that doesn't work, you'll get a third one. And so each successive operation, your chances of getting better go down, down, down. By the time you've had your 3rd or your 4th operation, you're almost somebody that can be classified as chronic pain syndrome.
Great. Well, let's talk about third category now, which is acupuncture and using things
Manual
like
medicine.
manual medicine. What is that a different category? I know it all fits into the continuum, but when would you employ that?
Under an umbrella of CAM, complementary and alternative medicine. And I think I've been moving my practice more in this direction, and healthcare in America is moving in this direction, moving away from the traditional allopathic medicine and medication and interventions more to a homeopathic and alternative care.
Isn't homeopathic kind of a funny thing? It's natural. I mean, it sounds a bit hokey.
It does, and that is that. Well, it does sound that way because I think the pharmaceutical companies, as well as many of the medical organizations, have poo-pooed that or basically thrown it aside. But actually, if you look in the UK, extensive studies have been done on homeopathy. And 30 to 40% of the patients improve within 1 to 2 weeks. It's amazing the results we've had. And the side effects with homeopathy are minimal. Same with acupuncture. You're just putting some needles in. And the Chinese have been doing this for thousands of years, and it works.
It does work. This medical marijuana, do you prescribe medical marijuana?
do not.
You do not? Do you prescribe?
I do. I'm part of the program.
Isn't that a danger in our society as well?
Well, these other medications, as we mentioned, the Vicodin and the Percocet, are similar to the medical marijuana, only that they are synthetic and they have many more side effects. Marijuana, at least, is a natural herbal medication and has far fewer side effects than the Percocet and the Vicodin.
Interesting. So let's do some fast moving round now in terms of types of pain, and me as a patient. How would I size up that pain, and what should I do what kind of questions should I be asking my doctor to get the best care, not just the doctor telling me what to do? How can I be a more intelligent patient? Dr. Malik, we'll start with you. Headaches.
If your headache has lasted over a week and it is not improved with any medications that you're taking over the counter, you're having problems with light, your neck is stiff, and you're running a slight fever. If it's got to that point, go see a doctor.
Great. And what should I ask the doctor?
Just tell them what your symptoms are.
Great.
Usually it's something very simple, like a sinus problem. But when it's gotten to that point, it needs to be looked at.
Needs to be looked at. Dr. Shahid, shoulder pain.
Shoulder pain can be manifestation of either a shoulder injury itself or radiation of pain from the neck disc. And again, this brings us back to the disc problem and pain in the back, whether that is neck pain or lower back pain. Dr. Aladin was mentioning his new camp at CAM. I believe that with the resources we have available in the United States, those surgeons working with interventional pain specialists tend to have better results. That is my practice, where the surgeons are sending patients back to the interventionalists to find out exactly where the pain is.
Where you can help.
So then the surgeons can do actually more educated treatment when it comes to taking care of those patients and have better outcomes.
That's helpful. Hip pain.
Hip pain can be coming from the hip itself or be coming from the back. And one should ask themselves, how did they injure the hip? Was it by lifting something? Is it worse? Does the hip pain go into the groin? If the pain goes into the groin, it most likely is coming from the hip. But if the pain stays on the side of the hip itself, there's a good chance that pain is coming from the back. It could be a sciatica, a pinched nerve as we talked about. It could be the joints, or known as the facet joints, F-A-C-E-T, those joints of the back. And it could be also the SI, or the sacroiliac joint. In any case, in those cases, we would begin physical therapy, the anti-inflammatories, as we mentioned before.
That makes sense. Dr. Shahid, knee pain.
Similarly, any pain in the limb could be either coming from the very specific joint itself, or it could be radiation or pain coming from a nerve that is coming from the back. So that needs to be triaged by the specialist. Knee pain itself is the primary cause of overuse. People
Runners typically have.
Yes, and they develop osteoarthritis. Treatment is again starting with physical therapy, if not interventional injections. If they fail, then definitely, if it is advanced arthritis, knee replacements.
Okay. Foot pain.
Actually, if you don't mind, I'd like to kind of elaborate on
The knee pain?
the shoulder and the knee pain. Usually what I ask them is, can you put your hand where it hurts? In your shoulder pain, if they put their hand up here on the side of the neck, it's usually coming from the neck. If they say it hurts right here, it's coming from the shoulder. Very similar with the knee. Ask them where the pain is. If they put their hand on the knee, invariably it's a bad knee. If they put their hand either on the front of the thigh or the back of the knee or the back of the calf, it's probably coming from your back.
That's a great. Now, foot pain.
I usually don't treat foot pain,
Okay.
but we see a lot of referred pain from the back into the foot.
It just
Usually you look for other causes of foot pain, most common being plantar fasciitis, where your patients come and say, my heel hurts. Every time I walk, my heel hurts.
Okay.
And if that's the cause, then obviously it's a foot problem and not a back
We've
problem.
got to keep moving. How do I assess my child's pain? How do I do that?
Child's pain, it can be for different causes, as of these we mentioned before. If the child says that when I throw my baseball it hurts, we're looking at the shoulder. And the child says, well, my pain is worse when I turn, then we're looking at the neck. So it's similar in the same way if it's when they go up or down stairs, or turning, pivoting in soccer or football, we're looking at the knee. But more when they bend over, we're looking at the back.
Got it. Now we tease doctors. They're in it for the money. That's why you become a doctor. I have reasonable amount of data that says that's not the case. Can we talk a little bit about social service? What do you three do when you're not working in America in hospitals? What type of social services do you do? We'll start on the other end. What do you do?
Well, I actually started with the military, so I consider that as a social service because
service,
I continue to serve the American veterans in the.
Were you in the military?
Yeah, I was in the military, U.S. Air Force.
Right.
So apart
was
from
your
that,
rank?
major.
Okay.
Yes. So apart from that, belonging to Ahmadiyya Muslim community, there has been many opportunities to serve the Jamaat. In different capacities. I've actually visited Rabwa and given my time.
Rabwa is a city in Pakistan?
A city in Pakistan, and I've given my time to the
hospital,
the charitable wing of our organization.
Pain doesn't live only in America, huh?
There, as a matter of fact, I'm an anesthesiologist. I went there as an
Okay.
anesthesiologist,
Great.
yes.
Thank you. Dr. Aladin?
Yes.
Tell us about your social service.
I've also worked with Humanity First, an organization dedicated to the promotion and the welfare of humanity. And with Humanity First, I went to Indonesia with the tsunami back in 2012.
Wow.
People were thrown from those huge waves that had come, and injuries to the back, neck, shoulder, knee. We treated those. Then also I went also to Haiti after the earthquake, and tried to help the victims there as they were crushed. They had many crush injuries that we had to treat there as well. And then also Hurricane Katrina and Rita down in New Orleans.
That's right.
I went there as well, able to serve the country. And then even locally, after Hurricane Sandy in Long Beach, I was able to do some service there. People were injured after all that water had come
Long
out.
Beach, not on the West Coast.
No, the Long Beach of Long Island. If it's not
Great.
Long Island, it's the wrong island.
Thank you. Dr. Malik?
Well, I've been fortunate enough to also visit Rabwa, which is a town in Pakistan that has a wonderful institute called the Tahir Heart Institute. Most of us are aware of it. It's doing wonderful work in that region of the country. I was there primarily as a fact-finding mission to see what we can do to set up neurosurgical services for that area. I've also had the occasion
You were
to...
doing neurosurgical services in the heart hospital?
In the area.
In the area, I see.
Correct, yeah. So obviously if we were going to start them, there's going to be an extension to that hospital.
Okay.
I've also been fortunate enough to visit Guatemala to see what we can do as far as providing medical services there. And more recently, we've been fortunate enough to get a hospital which we're trying to now develop and equip so that we can go do surgeries there.
Real quick, in America, there's Obamacare. In other countries, the care is questioned, and your whole industry is in question right now.
I agree with the Obamacare and the principle that everybody should have insurance. And as Huzur has mentioned, right?
His Holiness Mirza Masroor of the Muslim community,
exactly,
yes.
has mentioned. But at the same time, with the insurance companies confiscating or basically taking over the system, the patients have been hurt because they're paying higher deductibles and they're paying more for their insurance, getting less coverage. The physicians have been hurt with reimbursements.
We need to be careful how to do this.
On how to do it, because it's only the insurance companies who are benefiting here.
That's not good. Dr. Malik?
Obamacare is the law of the land. And whether we like it or not, we all have to abide by it. I wish there was a better way to fix the problems of healthcare that we face in the U.S.
Well, we have experienced nationalized healthcare. It exists in American military right now, and we have seen the fiascos that it has brought about.
Challenges.
So again, philosophy is good. How to implement is where we have a big vacuum.
This has been a show of Open Forum where we've learned about pain management with three nationally recognized experts in the subject. We learned about how to assess pain in the back, in the neck, in the shoulder, and the knee, and when to go to a doctor and what kind of questions to ask. We talked about surgical procedures, non-surgical procedures. We talked about acupuncture and homeopathy as well. Hopefully you learned from this, and this has been another production of Open Forum in Silver Spring, Maryland with MTA International. Thank you for joining us.